This is the Inside TRAQ. We discuss health, healthcare, and medical insurance simplified. Powered by Total Risk Administrators and the TRA experts Warren, Alan, Dr. Avron, Rena, Jeff, and Kim. Sharp insight, real conversations. Let's go.
Good day, and welcome to the Inside TRAQ. Today we're going to do things a bit differently. Those of you who watch our podcast regularly will know that Dr. Avron often interviews an industry expert in the healthcare field. Well, today he is going to be interviewing another industry expert. In fact, he's interviewing Stan Landau, who's a specialist at the Center for Diabetes and Endocrinology. That's right, today's podcast is all about diabetes. But before we go to that interview, something different. We'd like to introduce you to a patient. Me. That's right. On the 15th of February this year, I was diagnosed as type 2 diabetic. I must say my first reaction to hearing that news was one of great despair. I thought to myself, how could I have let myself get to a point where my blood sugar and what I was putting into my body and what I was doing to my body had got to a point where I was now a diabetic. I must say the words and the label of being diabetic seemed like a death sentence to me. I had heard horrific stories of what can happen if you have diabetes. But the reality is far, far different. Initially, there was a lot of guilt on my side. I thought, how could I have let myself get to this point? But then I realized that this was an opportunity. This was an opportunity to make my life different. And that's what I did. It wasn't about a knee-jerk reaction. It wasn't about this intense way of life. It was all about consistency. So I decided to do things a bit differently. I started watching what I was eating. No extra sugars. Lower the carb content. Avoid alcohol. All the things that were really just putting my body under a lot of strain. In addition, there was a lot more exercise and a constant awareness of actually living my life with a purpose so that my health became the most important aspect. You know, when I first got the diagnosis, I weighed in at just over 113 kilos and the level of sugar in my blood was very high. There's a standard test, a clinical test called the HbA1c, and that test basically measures 3 months of your blood glucose content. And that test came back in the upper tens. And that was a big fright because you slap bang in the middle of diabetic territory right there. So with all of these changes I made in my life, the consistency, diabetes doesn't ask you to be intense, but it does ask you to be consistent. And that's really what I relied on, is consistently every day doing what I needed to do. As I'm sitting here now, I've lost 12 kilos. My HbA1c is now down to 5.3. So I'm not even in a pre-diabetic phase. I'm in a normal phase that the average person in our population would have. And that is fantastic. But the journey is far from over. This will be a constant daily challenge for me going forward. But guess what? This is not about my story. This is about you. It's about you watching this podcast and watching this interview and deciding that you're going to do something about it. We know that 1 in every 10 South Africans has got some sort of form of diabetes. The sad thing is a lot of people don't know that. And you'll hear in this interview with Dr. Landau, many people are walking around in a diabetic state without even knowing it. So the big message from this podcast today is go and get tested. Let's listen to Doc Avron as he interviews Dr. Landau. This is a fantastic interview. You're going to get so much good information from you. And I'll chat to you again once the interview's finished. Let's have a listen to what they said.
Stan, welcome. So nice to have you on the podcast today.
Thanks for inviting me. I think any opportunity to be patient-facing with a topic as important as this, most welcome.
Well, we often hear type 2 diabetes spoken about, and people just talk about it. And it seems to me that it's incredibly common. Maybe you can just sort of give us an idea in terms of what is the incidence in South Africa? How common actually is diabetes, type 2, let's say?
We think type 2 diabetes is as common as 1 in 10 in this country, 10%. And in fact, there's some data that says it may be as high as it may be as high as 14%. And either way you look at it, it's a lot more than that, because most people with type 2 diabetes are yet to be diagnosed, and they're out there, they're well, and they don't necessarily know they have diabetes.
So in a way, it's a bit of a silent disease, maybe like hypertension, but maybe some symptoms develop a little earlier on. But can you explain for our listeners and our viewers of this podcast, in simple terms, what is actually happening in the body when someone develops diabetes?
So whatever form of diabetes a person has, whether it's the more common type 2 or perhaps even a diabetes in pregnancy, the hallmark of that condition is an elevation in blood sugar level or blood glucose levels. And we can measure those blood sugar levels on a finger prick machine that are widely available in that sense. So if the elevation in blood glucose is the common denominator amongst all people with diabetes, the higher your blood sugar level when you present with your diabetes will determine whether or not you have symptoms. And generally speaking, you need a blood sugar of above 12 or even 15 for there to be the classic symptoms that everybody knows about: weight loss and thirst and hunger and vaginal thrush and discharge from the penis, so to speak. Those generally manifest only when the sugars are pretty high. But for most people, they go for a life insurance checkup, perhaps. They go for a general medical. They go to a shopping center on an open day like World Diabetes Day in November. And lo and behold, their blood sugars are only modestly elevated. That's still diabetes. The fact that you feel well doesn't mean it's not real.
Right. And for our listeners, can you say, why is an elevated glucose detrimental to the body? What is actually happening there?
I think to answer that question, we need to define the idea that if you have diabetes, your blood sugar is above a particular level, and that's a fasting blood glucose level at a laboratory above 7. And that is the level and above which blood vessels in our body suffer harm as a consequence to the exposure to blood glucose over long periods of time. In other words, not just a week or a day, many months and many years, these blood vessels, both the small blood vessels in our eyes and our feet and in our kidneys and the large blood vessels in our heart and brain, are subjected to harm as a result of the elevated glucose. And one could think of it almost as if you were taking sandpaper and roughing up the inside of this blood vessel. And that leads to scarring and harm within the blood vessel, which makes the blood vessel more prone to block up, even rupture. And depending on where that happens in the body will determine what kind of harm may develop from diabetes.
So Stan, I think that leads us nicely into early warning signs. I'm often asked this, and I think it's really important for our viewers and listeners. What are the early signs or risk factors that people should watch for, especially symptoms that are often ignored in early diabetes?
I think, as we alluded to already, the common symptoms such as thirst, urination, unexplained weight loss, perhaps recurrent infections, recurrent urinary infections, recurrent vaginal thrush in women are all clues that diabetes may be manifesting at this point in time. The commonest symptom of undiagnosed diabetes is there is no symptom of undiagnosed diabetes, because you can feel absolutely well and be walking around with a blood sugar of 10.5. And that's a pretty high level, even though you feel well. So I think rather than waiting for people to come in with the advanced symptoms of their diabetes, we should be looking at the population at large, people over the age of 40, people in large bodies, people who have a family history of diabetes, people who have heart disease, people who take cortisone over long periods of time. Those are the people who should be screened more frequently to ensure that they don't have diabetes, even though they may feel well and have no symptoms.
So I think that's great, and I think for early warning signs is a screening factor for our listeners and viewers. But so in terms of blood tests, right, testing for the blood glucose, should adults be doing it once a year, as a lot of the screening programs do?
So if you regard yourself as high enough risk, perhaps you come from a family that's, layered with diabetes, or perhaps you are over 40 and in a large body, for example, it's imperative that you have a blood glucose level tested. Now, we could split hairs whether that's annually, if you have the means to have that done, but it has to be done in a laboratory setting. It can't be diagnosed on a finger prick blood glucose machine. That's very nice for people who already have diabetes and who are monitoring their sugars. But to be labeled and to be diagnosed as having diabetes, you have to have a blood test in a laboratory. And there are different ways that you can diagnose diabetes in the laboratory, whether it be a formal fasting glucose test or a test called the HbA1c, as long as it's being done and as long as the result is interpreted correctly. Because, Avram, let me tell you, one of the greatest challenges we have in South Africa and probably around the world is this idea that if you have type 2 diabetes, it's mild, it's a touch of sugar, it's light diabetes, it's not the bad one, it's maybe the good one, it's the one that doesn't require insulin. That we know is nonsense. If you have diabetes, high blood glucose levels, then you have diabetes. It's not good, it's not bad, it's not mild, it's not chronic, it's not severe, it just is diabetes. And we must move away from using language like that, because often the practitioner and the person with diabetes can get under the impression, or get the impression rather, that the condition's quite mild. And if the doctor's not so worried, then why do I have to be worried in that sense? So, yep, get tested, know your number, and then you can embark on a treatment profile that will ultimately lead to success. I don't think it's said enough, everyone. Just because we're talking about diabetes doesn't mean it's a hopeless situation that harms are likely to develop. I think there's a big difference between well-managed diabetes and poorly managed diabetes.
And we definitely want to go on and discuss that. But for individuals, and a person who's just been diagnosed, he's shocked, he wants to know, is this a chronic disease? So I want to talk about reversibility and progression, right? Is it a reversible disease, a manageable disease, or is it inevitably progressive?
So if we think of the insulin producing organ in our body, the pancreas, which is nicely tucked up behind the stomach, by the time a person is already diagnosed with type 2 diabetes, they've already lost a lot of functioning in that gland. And when we talk about functioning in the gland, we mean how their insulin, the hormone we have in our body that lowers blood sugar, is working less efficiently. Ultimately, if we were going to make a dent in diabetes, it would be great if we could find people long before they developed diabetes, when their tank of insulin was pretty full, and we could slow down the probability of developing diabetes. But you ask a great question, because if your diabetes type 2 is caught early enough after diagnosis, there are many strategies that you can entertain at probably halting the condition and reversing it. In other words, putting the diabetes into remission. It is by definition a chronic condition because its very nature is that of a chronic. It's an ongoing thing. Sure, you can put it into remission, but even if you put your diabetes into remission, you're still careful. You still have to be considerate in terms of how you're managing your health and well-being. It's not like a cancer that one puts into remission and you can forget about it 20 years later. You put your diabetes into remission, you've still got a lot of work ahead of you at that stage. But yep, remission is doable.
So if you diagnose it early enough and you treat it correctly, we'll talk a bit about that, you can potentially reverse it. And that should be an incentive for individuals, if they are diagnosed, to try and treat it as most efficiently as possible. Let's move on to lifestyle as treatment, right? Someone's now newly diagnosed. What lifestyle changes would you say have the strongest scientific evidence for improving blood sugar control?
So if we're talking about lifestyle components, what we're ultimately talking at, what actions can a person do to manage to bring their blood sugar levels down within a range that's going to be regarded as safe? Now, if that range, let's say, is between keeping your blood sugar between 4 and 8, we need to recognize that's a pretty strict range. And therefore, the interventions that are regarded as conservative, in other words, non-drug based, need to be pretty awesome in order to achieve that. You can't just do a little bit of something and have an expectation that that alone is going to do. So to answer your question directly, you need to engage in structured physical activity. You need to be undertaking this physical activity somewhere between 120, 150 minutes per week. And that needs to be a mix between aerobic and resistance kinds of activities, because we know that that's how much it takes to get your blood glucose well managed. Now, what that means is that's an ultimate level that somebody should be aiming for in terms of their blood glucose levels. If you're an older person and you have arthritis of your knees and you've had hip surgery, for example, it's unlikely that within a few weeks you're going to be able to achieve those kinds of outcomes. So we recognize that these guideline-based or these evidence outcomes are the aspirational targets we need to get to. Many people
Sure.
haven't exercised for years, and in fact, it's regarded as a swear word. So perhaps we start off with movement.
Mhm.
So that forms the foundation of management of diabetes.
Okay, so exercise is key. Obviously, cardio and muscle strengthening, as you spoke about. Diet, I would assume, plays an essential role here. And to me, and we often get questions around that, but there's a lot of diet confusion, right? Conflicting advice about diets. Low carb, Mediterranean, plant-based, intermittent fasting. What actually works for most people who have been diagnosed with type 2 diabetes?
So I want to be a bit controversial here because the thing that works the most is taking the word diet out of the equation and using
Yes.
a concept such as medical nutrition therapy, because we need to recognize that if we're going to improve the quality of outcomes for people with diabetes and lower their risk of harms and improve their blood sugar levels, whatever nutrition intervention we're undertaking is actually medically grounded. It's not some frivolous thing that you're going to read off the back of a matchbox. It really has to be done under a guided, supervised manner that you can achieve the outcomes that are expected. And we don't play around with that word lightly. So medical nutrition treatment is powerful treatment on its own right. And in essence, if you take the sum of the data globally, there's very little difference between the outcomes in terms of blood glucose lowering. And the reason for that is because there are a billion people who have diabetes, not quite,
Sure.
but a billion people who have diabetes, each who come from different cultural backgrounds, who come from different budget backgrounds, preferences, tastes, different families, and that's it. So when one looks at what's the most appropriate medical nutrition treatment, it has to be individualized. It also has to be sustainable over the long term. You're not just aiming to lower blood sugar levels in the short term. This is, as we alluded to, if you're not putting it into remission, it is a chronic condition.
So would you say, obviously, one should obviously visit a dietitian, obviously, to work out the best plan that works for the individual, a sustained plan for medical nutrition therapy, as you spoke about?
Now, we recognize that we're all human. I don't have a
Mm.
chronic medical condition as such, but I recognize from dealing with people with diabetes, it's hard to adhere to these kinds of therapeutic interventions, such as lifestyle
Mm.
changes. And everyone, that's where your expertise comes in behavioral changes in that sense.
Mm.
So it's good and well to have an aspirational idea, but we also need to provide the support that will allow an enduring components, because people go on holiday. There are religious feasts. There are times when people's homes are being renovated, that it isn't always possible to be as physically active as you wish. And we must acknowledge that right at the beginning, is that we're aiming to do the right thing most of the time. I don't think it's
Right.
realistic that people can do everything all of the time with their
Sure.
diabetes.
Sure. So we've spoken about exercise and diet as lifestyle modifications. Any other lifestyle modifications that
Sure, I mean,
that you can discuss?
there's more and more of this coming through all the time. Long before we get
Mm.
to, prescriptive treatments, one needs to be absolutely sure that you're getting enough good quality sleep. And data after data is telling us that we need to be sure that we're getting enough sleep. We know that this is key. Disruptive sleep has a profound impact on worsening blood glucose levels. We're seeing much more impact on both environmental stress, in other words, airborne pollutants and like, as well as the ambient stress we have in our day to day. And those attributes of care need to be recognized as well, as does the ability to have, believe it or not, lots of work on bowel health now, and how these
Mm.
good versus bad bacteria in our bowel are also key to the management of diabetes. So diabetes from a therapy point of view encompasses, a lot more than we used to think. Diet, exercise, and a pill. The whole person's being now needs to be considered in that sense. So you need to quit smoking. You need to be modest with your alcohol consumption, if not abstain, particularly if you have perhaps fatty liver disease, which often goes hand in hand with diabetes. And those are the kinds of things that make up a comprehensive conservative package. In other words, non-drug based treatments for diabetes.
Right. And I think that gives an overview and the importance, which is often seems to me skipped, and doctors, healthcare professionals move straight onto the drug treatment, let's say. But I think a lot of time and energy needs to be put into the non-medication lifestyle modifications, and individuals need to take it seriously.
I mean,
Moving on.
yeah.
Sorry, go ahead.
Much like anybody who's planning for their financial independence in that sense, this is a long haul
Yes.
component. This isn't something that somebody's going to start saying, from tomorrow morning, I'll run 20 kilometers. And they hurt their knee on day one. They hate their physical exercise. And in fact, the whole house of cards comes crashing down. There needs to be a good strategy in place, a feasibility and an understanding of what are the expectations. How will they go about making these changes long before they put their tackies on and hit the road for the first time? And I think that's an important message, is that it's never urgent to massively get the diabetes under management, on day one. It can feel overwhelming, and people want to start making a fuss from day one because of all the rumors out there in terms of what can happen. But there's nothing that says you can't plan for this over a period of time so that you're likely to succeed in your execution.
Yeah. It's a marathon, not a sprint, right? So,
Yeah.
and one has to plan accordingly. Let's move
Point
on
well
to the
made.
medication.
Oh.
Let's move on to the medications, right? If you can just give a high level overview in terms of where generally, if you're diagnosed with type 2 diabetes, where will you start and how do you progress? And is it a definite that you're eventually going to land up on insulin?
So in the modern day, we don't regard medicine as an add-on to the failure of nutrition and exercise. There are many cases where treatment, oral medications, possibly even injectable medications, are appropriate from the get-go. So being on a medication for type 2 diabetes doesn't represent a failure. It's often highly
Yes.
necessary in a large number of people. And we need to recognize that whatever treatment, whether it's nutrition, whether it's physical activity or medication, the only way you can adjudicate the success of these treatments is if you're monitoring your blood sugar levels. So we would ordinarily introduce oral medication, or in certain cases, injection-based treatments, if the blood glucose levels were outside of the target level for that particular person. So it's no good that you're wandering around town being active and eating appropriately, and yet your blood sugar levels are 10. All that's telling us is that your nutrition and exercise alone isn't enough to introduce oral medication. And because we have an enormous smorgasbord of treatment available to us, again, we tailor the treatment of medications for diabetes according to who the person is. Not everybody is appropriately going to be put on particular treatments. Some people it's contraindicated or off limits. Other people may have liver or kidney disease. So whatever's appropriate for you may bear no correlation for the person, who comes after you, or a family member. Each person's treatment is unique, but the common denominator then is that everybody's treatment needs to do the job to attain the outcomes that will determine the success in the long term.
Right. So, I mean, there are oral tablets, there's insulin, as we know. And in the last few years, there have been these breakthroughs, right, in medications, which seem a lot of people are speaking about. And we're talking here about the GLP-1s and the SGLT2 inhibitors, just for our listeners and viewers, medications like Ozempic and Manjaro, which have been spoken about. How effective, and I mean, this is the big talk of the town, as we know at the moment. How effective are those actually in controlling diabetes, and do you have a significant amount of patients on them?
So I think anybody working in diabetes medicine, in an affluent, in a medical aid funded environment, will no doubt have lots of experience with these GLP-1 treatments, whether the older daily versions or the weekly versions now. They are incredibly powerful treatment and need to be really supervised under a medication kind of umbrella, because they're not without their ill effects, they're not without their harms that may manifest. And similarly, the oral medication you alluded to, we loosely call the Flozin family, they're also pretty powerful in that sense, but they are only medications. And we need to recognize that if you're taking a weekly GLP-1 treatment, what these drugs cannot do is increase your physical activity. They cannot make your nutrition better. They cannot lower blood glucose, dramatically to the extent that insulin can. So even if somebody is on one of these more contemporary medications, it doesn't imply that it's inherently going to be successful, and they may still need an insulin-based treatment. And we have lots and lots of people who are unable to tolerate Ozempic through no fault of theirs. They literally can't take it, in which case one has to look for something more powerful, such as an insulin-based treatment. Yep, they have changed the landscape. They're offering some excellent value, but the price point remains a big deal in our country.
Yeah. Are they, and would it be such the medical funds, would they fund them for diabetics, the new types of treatments?
In this country, the funders take a very kind of glazed view in that sense. There are certain funders that have specific hoops that you need to jump through in order to qualify for therapy. And unfortunately, even if you qualify for therapy, there's almost always going to be a co-payment. I will say this, though, that, and this is something I teach about, and this is something I use in daily practice, these therapies are forever therapies. There is no prospect of GLP-1 treatment being withdrawn because of ultimate need. If it's being used for the management of diabetes, or it's being used in the management of somebody with underlying cardiovascular disease, heart failure, or possibly a stroke, there's no intention at the beginning of therapy to ever consider stopping them. We would have no mindset of stopping epilepsy medicine or asthma inhalers or blood pressure treatment. So they need to be understood as forever drugs. Sure, they can be stopped, but one would question why that would be the case. Perhaps it's a side effect issue. Unfortunately, globally, we know most people stop these drugs because funding runs out.
Sure. So one has to realize that it's a long-term therapy. I suppose whatever therapy you're going on for diabetes, as we spoke about, it's long-term. Stan, technology and monitoring, right? There are a lot of new monitoring tools, digital health apps. How are they assisting people in terms of managing or changing the way people manage their diabetes? Have you found it effective?
Yeah, it's a great question. I generally see two kinds of people who are making use of modern technology. And the first sounds like an unbelievable group. And, when you hear it, you'll think, how's this even possible? The first group are people who are generally people of means, who love wearing these modern day techs, and they see their blood glucose levels chop and change over a period of time, yet they fail to act on that data. And the entire value proposition of the technology is that the data that's gleaned from these wearables must be acted upon. Otherwise, all you're doing is spending money to look at, suboptimal data. So they are game changers. And I don't have diabetes, but for people who make use of continuous blood glucose monitoring devices, particularly the population with type 1 diabetes, which is a much smaller fraction of diabetes globally, it's a game changer for them because they've had to rely on uncomfortable finger prick testing for many, many decades. And were cost not an issue, it would be wonderful if wearable tech was the be-all and end-all from a monitoring point of view. You get instant feedback. For many people, that's immediate learning, and modification and behavior change can follow after that. So it's very rewarding to see how people's behaviors follow data, which ultimately follows behavior, which follows data, and it becomes a very fulfilling, forward-facing cycle, in my opinion.
So for those who use it effectively, very beneficial, but you obviously have to take it seriously. I suppose like anyone monitoring their health apps.
Very much so.
Psychological and emotional impact, which I like to bring into the management of chronic conditions, right? Living with this chronic condition, I'm sure it can be exhausting, challenging from a mental wellness perspective. How often do you see that? How do you deal with it in terms of diabetic management?
Yeah, a great point. I think that chronic disease and mental health matters are intimately linked in that sense. And even if somebody's going to work hard at, getting on top of their management, there's always that initial kind of that almost bereavement component, the shock and the denial and, all of those ruminations that manifest in people who are handed a label such as diabetes. Doesn't mean it's going to define how they are going forward, but we need to recognize that perhaps mental health aspects are no less important than nutrition and structured physical activity. And a lot of people need support. People may already come to us with harms from diabetes, or perhaps have great anxieties about harms from diabetes because perhaps an uncle 30 years ago lost a leg, and perhaps that's their expectation, or perhaps that's their reality of diabetes. So good mental health stalks diabetes management very, very carefully, and lots of people aren't in a great space. Unfortunately, the stresses that are ambient that may have aggravated their development of diabetes also need to be tackled in the greater treatment profile for them.
So should those individuals, and if you are affected, I presume you should reach out in terms of counseling or therapy if you're struggling with that as a chronic disease.
I'll say something here that holds true for any chronic disease, whether it be epilepsy, asthma, multiple sclerosis, diabetes, and we're seeing this more and more. The only treatment really that has an evidence base that can prolong the life, I would argue, in a person with a chronic disease is probably knowledge. It doesn't matter whether you can
Great
afford
point.
Ozempic and if you can afford a
Yes.
continuous monitor. If you don't understand the fundamentals of your condition and nobody sat with you, whether it be a lay counselor, whether it be somebody like a diabetes nurse specialist, you're going to struggle to understand the expectations because a person needs to understand
Yes.
that when they are diagnosed with a chronic condition, their body has changed and their body's functionality is not as optimal as they had either perceived it to be or won't be in the years to come. And these aren't the body options that people have necessarily chosen for the rest of their life in that sense. And that hurdle of kind of coping with this, the loss that comes, I used to love eating out. How do we modify that? I used to love and now I can't. And all of those
Yes.
aspects need to come into the picture. And that's really where knowledge comes from. So good diabetes looks like good knowledge. And very often that's a person who can become an advocate for other people with diabetes, who can dispel many of the nonsense
Sure.
rumors that stalk this condition and can in fact be very good for the people around them in their own community and within their own family.
So, Stan, in your experience, and yeah, I mean, I'm quite passionate about health span, lifespan, longevity, etc. Someone who manages their diabetes effectively, sort of takes on a lot of the points that we've discussed today, etc. Would their longevity or health span approximate individual without diabetes?
Broadly speaking, you have to get to 70 years. After 70 years,
Yes,
all bets are off because we're all kind
yes,
of older at that point in time.
yes,
Unfortunately, for a group of people, the younger they are diagnosed with their type 2 diabetes, they're the ones who can run into trouble more likely. So if you're 42, for example, you've got a long haul to get to 90. Whereas if your grandmother only got diabetes at 88, that's a different kind of diabetes in that sense. But it really depends on your attitude in terms of what's going to be done. I think there's too much hopelessness out there, and there aren't always enough positive messages about diabetes. And in fact, just a quick anecdote from our clinic, we've got the country's first professional airline pilot. He's a young man with type 1 diabetes. He loves his name being handed out there. It's Captain Jonathan Collins. Why it's important? Because he lost his job the
yes.
day he was diagnosed with type 1 diabetes. He fought the law
Oh,
and he overturned aviation legislation in South Africa. And if you have diabetes in this country, you can now fly in certain conditions. So why is that important? Because it shouldn't need to limit the person's life.
yes.
You may not get a commercial airline pilot. You may not be allowed to become an astronaut, but you can donate blood. You can scuba dive. So, yeah, I guess attitude determines the outcome for many, many people. And if we as healthcare providers can share that positivity, it doesn't need to be the condition that's often perceived as a death sentence or an early grave. I think that's diabetes in the 1950s. I think people are thriving more and more today with good knowledge, good nutrition, good physical activity, mental health matters, and yes, appropriate use of medication.
That's an amazing story, and I think very inspiring. And Stan, looking ahead, what developments in diabetes care are you most excited about? What are you seeing in the future? Where's the landscape going?
Well, I think at the moment we've pretty much reached a plateau in our therapy. Sure, there are going to be different GLPs coming out. And yeah, we've got a weekly insulin coming onto the market in due course. Great. It's still therapy. We're not really moving the needle. I think a lot more efforts in this country should be aimed at the so-called very low calorie diet and the remission of early onset type 2 diabetes. This very well described by Roy Taylor at Newcastle University in the UK. So that's kept me excited for more than a decade. The second thing that's exciting, not necessarily for this audience, but in type 1 diabetes, lots of beta cell or insulin production cell within the pancreas preservation. Lots of work being done on how to screen for early diabetes, how to intervene with antibody treatment and change the time course of type 1 diabetes, and kind of working a lot on that. Stem cell technology out of China, absolutely wonderful, and some new data out this week from the US in terms of studies kind of delaying the disease of type 1 diabetes. So we've never had it this good, so to speak.
So we're talking there about gene therapy as well. Could that be applicable for type 2 diabetes at all?
It's not something specific that applies like a single gene abnormality,
Yes.
perhaps as a genetic condition that a child might be born with, and the parents can cut out a gene and insert something healthier. Not quite in that lines, and that's because type 1, type 2 diabetes, there's more than one cause. It's not a linear relationship where you do this
Sure.
and then you get that. So gene therapy, not necessarily something knocking on our doors at this point in time, but conceptually, certainly something that would be reasonable going forward.
Right. Excellent messages. Stan, as we conclude our podcast, and it's been really fascinating and enlightening for our listeners out there, those with type 2 diabetes or diabetes in general, what message do you want to leave with them? I mean, we've spoken about a lot in our podcast, but some final concluding points.
I'll make it simple. The American Diabetes Association had this tagline a couple of years ago. It said as following: diabetes is tough, but it's worth it. And I think that's a very positive message to say. It's not easy to manage diabetes. We sit here and we talk diet and exercise. You know, our patients have jobs and families, and they do all the other bits and pieces that they need to do with their lives. And sure, it's tough, but ultimately it is worth it in the long haul.
Amazing. Dr. Stan Landau, diabetic educator, physician from the Center for Diabetes and Endocrinology in Johannesburg. Thank you so much. It's been really enlightening, and hopefully we'll bring you back onto the podcast to discuss other topics in type 1 and type 2 diabetes. Thank you so much.
Thanks for the opportunity, Evan.
Well, there we go. I mean, that was a fantastic interview. And again, from my point of view, my message to everyone is a diabetes diagnosis does not mean the end of your life. It is not a death sentence. I'm living proof that with a bit of consistency and dedication, you'll be able to turn your diagnosis around. So go get tested, know your numbers, and start living a new chapter in your life. One where you're in control of your life, not the other way around. Thank you for watching our podcast, and as usual, let's hand over to Gappy. Bye for now.
Don't stress, the gap is covered.